Welcome to the very last module of Nursing 516, where we examine a healthcare leader's role in building knowledge. In other words, how can leaders ensure that continuous quality improvement takes place in a healthy way and we continue to build on what we know to enhance systems and hopefully make for better patient outcomes? So as we build knowledge to base our policies and procedures on and how we deliver care, Maccabee talks about going from a descriptive theory to a normative theory. So we start by observing and describing phenomena and categorize those, and we might come up with some preliminary correlations that we test on a small scale and then move to implement that throughout the system. And eventually we come up with a stronger theory or evidence-based practice where we say, gee, if we do this, then we implement X, then Y will happen. Although I take issue a little bit with Maccabee on that, and that in research we very rarely use the statement causality. We usually always say associated with. And one of the reasons is that people are very complex. So unless you're doing test tube science, and even then there can be, of course, quite a bit of variation, but certainly with people and systems, we still can look at things in terms, it'll be highly associated, but not necessarily a cause and effect relationship. But it is important to base what we do on some tested theories before we move ahead to perhaps expand something into the whole system across a healthcare system or whatever. And certainly we're going to want to look at, depending upon where we're studying the problem or implementing something new, it will depend on the circumstances in which we're studying. We're not going to approach patients waiting in the emergency room and triaging them in the same way we might approach that quality problem in a clinic. Thankfully, things have really changed since I was a young nurse, and there was a lot of emphasis on simply compiling data and not coming up with an underlying theory of what was going on. It was really looking more at outputs. We called it quality assurance, and it was always retrospective, looking back at what had happened over the month, and usually centered on documentation or completing a task, rather than really look at what was going on with the patients that we were serving. So we'd have these big elaborate charts on the bulletin board put together by somebody who worked in quality assurance about how often we were documenting something, patient education or whatever it was, and nobody really looked at the system to see was what was in place really supporting getting that done. And my favorite was the lady who would run around checking the juice cans when I was at the Sisters of Providence. We didn't have single-use juice. We had big cans that we'd put, we'd take an opener and just old-fashioned opener and make a couple of holes in the top, and then we'd pour juice for patients. Well, she was bound and determined that we were going to date those cans. It was really important to her, and of course we're running around giving care, and we could care less about whether there's dates on the juice cans. For one thing, we went through juice so fast on the postpartum unit, there was no way it was going to be outdated. But boy, we'd see her coming down the hall, and we'd quickly rush in and date the tops of the cans or throw them out before she got there so that she wouldn't give us a black mark, because it was like anything but to deal with her. And what that did for the patient, I have no idea, because I would like to think that if we poured out some juice that looked a little murky or moldy or something, we wouldn't give it to the patient. So thankfully, things have changed to be more outcome oriented. So in order to build knowledge that's really helpful in changing systems and behaviors, we need to use what's called the double loop learning process rather than just the single loop. So in the previous slide, I talked about the good old days, or the terrible old days in many respects, where we just kept going back to the actions in a single loop and saying, well, if we just work harder, or we keep reminding people in staff meetings, which is what would happen every month, you're doing a terrible job, you need to you need to go back and document that patient education or document whatever it was you're supposed to be doing, or label the juice scans, my favorite. And it would be the same old thing, and the next month we get the same old results, and people would run out, they'd get busy, they'd forget. So rather than looking at the underlying operating values or the assumptions that people were making or the environment to really change the system, which is in the double loop model, which is the only way to really change the overarching system of how we're delivering care. So as we talk about double loop learning, what does that mean to go back to the underlying mental models or assumptions that people are making outside of just the system that's supporting the work that we do? Well, mental models are those representations of some aspect of our experience that we have in our brain, and they're based on prior experience and memory, and we all have them. And so when we are learning things that are new, we always go back to our existing knowledge and experiences to process that, for it to make sense. So, so when someone tells you something that doesn't agree with those mental models, your first thought is, oh, that has to be wrong. So how do we change those mental models? Well, we demonstrate with data and so forth to try to get people to shift their belief systems. And I actually just had this happen to me last week. I was talking to a student about an idea she had for a scholarly project, and she's very, very passionate about providers prescribing IUDs for adolescents and teens, that it's a very effective birth control method, and why don't we do it more often? And I said, well, gee, now this, I said, I actually don't know much about what's going on now, but my experience is that it can, certainly some of the old models of IUDs can cause infertility and lots of problems for women, and they're very uncomfortable, lots of cramping, bleeding. I said it would be probably the last thing I would recommend to my adolescent daughter. Well, she's now 22, but in the last few years. But that's where my mental model had actually come from, in my experience, that was outdated and old. And the student was really lovely and trying to educate me. Well, that's really changed. We have different IUDs now. Can I send you an article on this topic? And I said, sure. It was an excellent article, and it really did start to get me to change my belief system a little bit. But it's difficult, and we all have those mental models based on our own experiences and existing knowledge. Sometimes it's about another discipline. I run into nurses, physicians, whoever, who have different ideas about each other and why something won't work. Well, I need to do this because the doctors won't listen to me. They won't follow through on this, so I need to do it this way. Things like that. So challenging people's mental models is tricky, takes a lot of energy, but a good leader can do it with the data behind him or her. So equally important in healthcare, as we're measuring outcomes and so forth, that we have specific shared definitions. And the one that Maccabee talks about is a fall. What do we mean by a fall? And there's two examples here. One is a sudden, uncontrolled, unintentional downward displacement of the body to the ground. This is actually way more detailed than I would make it. But this is from more of a violent blow or other purposeful action. So someone has shoved you over, or you've run into something and fallen over, as opposed to an inadvertently coming to rest on the ground, uh, or perhaps rest on a furniture wall or other objects. Now this seems kind of obvious. Well, gee, we know when a patient falls in the hospital, but actually, when I'm over at Cherry Hill campus, we have a big rehab unit there, and they define falls somewhat differently than we define them on the acute care areas, because it's important for them to differentiate between a controlled fall and someone who does fall. So quite often what will happen is someone's recovering from a stroke, and they're trying to walk, and there's someone there with them with the belt around them, and the patient's like, oh, I'm going to fall, I'm going to fall. And so it's a very controlled fall with someone helping them to the ground, as opposed to someone trying to get up to go to the bathroom, and they're by themselves, and they fall and really hurt themselves. So we do differentiate between those two types of falls, because the controlled fall is not something that goes into our um, sort of blacklist of falls, so to speak, that we're gathering data on of number of falls per month. So it's really important that we have these shared definitions and shared models as we do the model for improvement, or as we implement that model of improvement, the ACT plan, do, study model that we see everywhere in CQI, because we want to agree on just what is it that we're trying to accomplish, and how will we know that there's a change or an improvement. So if we have that shared measurement that we're all in agreement around, we'll know. And then what change can we make that will result in that improvement? And then this slide is just looking more specifically at that PDSA cycle, where we decide what changes need to be made, and then have our plan to carry out on perhaps a small scale at first, looking at data collection, looking at the patterns, and then carrying out the plan, making the changes, and analyzing the new data that we gather, and then coming back to study, where we complete the analysis and compare the data to our predictions based on the theory, and then perhaps adjusting the theory that we had to say, gee, it looks like what was highly associated with these implementation is really not exactly what we thought. So that cycle just goes around and around until we get a more robust theory based on a larger and larger data set. And what's really nice about the PDSA cycle is, we can use it to increase or change those mental models and get people to believe in what we're doing. If we can show the evidence that over time we can show these associations, and that really is making some positive changes in patient outcomes, or whatever it is that we're trying to improve. And this slide just shows the multiple PDSA cycles over time, and how they all work together to build knowledge. So we start with some observations, as we talked about at the beginning of this chapter, for the beginnings of engineering theories, looking at our own observations of phenomena and so forth. And then we make some very small scale testing. We implement, does it work? And then go back and tweak it, and continually improve and do larger and larger cycles until we really implement it across the system. And at the top says have a breakthrough result, but hopefully you've had several breakthroughs along the way that really lay the foundation for system-wide change. And this is a summary of really a lot of things that we've learned throughout the quarter about methods for improving learning and outcomes, starting by looking at based on the phenomena that you've observed, what are your predictions for what might happen when you make the changes? Consider what other outcomes might have occurred. Develop shared operational definitions of concepts before you start measuring, and ask open-ended questions to confirm or disconfirm your beliefs, not just yes or no questions. Constantly be questioning your own mental models and beliefs based on your past experience. Use control charts and the theory of variation that we learned about from Chapter 7 to understand and interpret the data that you're seeing. Is it special or common cause variations? Because as we learned before, those can lead to very different actions. Go back and test and experiment on a small scale and until you get on their stand helping me